So whenever we have a patient coming in for an exam with a doctor where the patient and the owner is going to be staying in the clinic, we have a regular admission form. It has all of the patient's information here, owner's name, the signalment of the patient. This one is for Ginger Wild. Her breed is a terrier mix. She is a canine. We have her age at 7 years. She is a female spayed black and tan terrier mix. This has her weight on here, the doctor that she's going to be seeing, her appointment time, and then this sheet also has all of our common services that we have, all of our exams, vaccines, blood work and testing, any kind of grooming services over here, and then preventions. We also have an area down here if you needed to write anything in for the receptionist to add. This section down here is all of the patient's reminders, so when they are due for their vaccines and preventions. And then up here at the top of our sheet, we have whenever their next appointment needs to be scheduled, or any kind of notes for the receptionist to see whenever they go to check out the patient. So that is our regular appointment check-in sheet. Another thing that we have on all of our appointment admission forms is a section for alerts. If the patient has vaccine reactions, or as this patient has an alert that says all CBCs should go to IDEX versus doing them in-house in our lab. We prefer to send, at least on this patient, to a reference lab. So any kind of important reminders and alerts here. This one has vaccine suspended, and then her previous name and any kind of information that would be pertinent to that appointment. So in addition to our admission forms and things like that, we do have permanent records that stay on the computer, which show all of the reminders for the patient, as well as the previous history. If they've been to another clinic, that's where we would put their previous records. So I can show that now. So this is for my dog here, and it has all of her information, her signalment, her reminders are over here, all of her treatments that we've done in the practice, and then all the way down here we would have her previous medical records. And that all stays in our database. So for surgery appointments, each of our surgeries is going to have a surgery check-in sheet, an estimate, cage card, a paper collar that has name and our information on it in case the pet got out. It would have our information on it so that whoever found the pet could give us a call and return them to us. If we were to send out any kind of lab work, then they would also have lab forms, anesthesia forms, and then discharge instructions. For our surgery admission forms, it's going to have the patient signalment, her name, age, sex, breed. This goes over all of the expected procedures that we're going to do, and that we require and recommend blood work. Required over the age of 7, and it's recommended a smaller panel under the age of 7. We have them read and either initial that they accept or decline it. On the back here, it has a spot to check for if they want a microchip, and then as well as the disclaimers that anything can happen under anesthesia. We will use our best judgment and our best medicine to practice that will not happen, any kind of complications or anything. And then has their signature, the date, and then a phone number that they can be reached at today. And then down here it has who admitted them, so we know the technician that admitted them into the hospital in case we have any questions. For the estimate, I made an estimate for my personal dog if we were going to do a dental cleaning. This has our phone number, the doctor's information, and that this states that everything on here does not include any treatments that is not expected to happen with the dental, but this is what we are planning for. Everything on here is explained by each individual line item. We have the pre-anesthetic profile, the urinalysis that comes with the pre-anesthetic profile, the dental pre-op sedation, the dental catheter, anesthesia induction, the gas anesthesia, the actual cleaning and polishing, fluoride dental treatments, the anesthesia monitoring, which includes the ECG, ETCO2, pulse ox, and blood pressure. And then we have the day of hospitalization and then full mouth radiographs. So this has all of the individual charges and then the total charge as well down here. And then this will give you a range in the low end, like if we didn't do x-rays, then there's a low end and then the high end. All down here is the disclaimer, and then they would sign and put their contact information. Anytime a patient is admitted into the hospital and they have to stay in a kennel or a run, they are going to get a cage card. We have paper cage cards. These have the owner's name, the pet's name, the date they arrive, the date they are leaving, if they need a bath. And then we have vaccinations, any belongings that are left, and then what they're here for. So we have the dental, grade 2, full mouth rads, and then we're also going to check ears. And then we have all down here the dates, and then when they're fed, if they ate, when they were walked, their urine and stool output, and then if they had any meds. All of these would be filled out if they stayed for boarding. This one is going to have surgery, so we've just marked on here that this patient is going to be NPO'd for this day that they're here. And then at the bottom we have the breed, the markings and colorings, and then if it is male or female, castrated or spayed. Along with that, we also have paper collars that we attach to all of the canines that are here. We don't particularly place them on cats. We don't use collars that are not breakaway on any kind of cats. But it would have the animal's name, our information, and then our phone number in case the pet did escape from the clinic, unfortunately, so that whoever hopefully found the pet would be able to contact us and get it back into our possession. With the paper collars that we put on our animals, we have different colors. So we use red for dentals, green for boarding, blue for surgery, yellow for just drop-offs in clinic that are staying for testing and things like that. So each individual class of drop-off is going to have a different color, so that helps us stay on top of what that patient's here for, if it is surgery or if it's just a drop-off. In case we have 4 different sassies in the clinic that day, it does narrow that down a little bit. If we were to do any kind of lab work or sending out histopaths for our surgeries, preferably we do in-house lab work so we can get the results within 10 minutes. But if there was any kind of additional testing that we don't have here, like specialized thyroid testing or cancer screenings and things like that, we do have specific forms that we send out. These we don't particularly use all the time. We usually print out forms from our AVMA system, but this is a handwritten form that we could send to IDEX if our computer system was down or in any kind of weird case like that. So this has our information, our clinic's information, the patient's information, the owner's information, the signalment, and then all of the tests that IDEX has to offer. And then we would send one copy with the sample, and then we would keep a copy for our records. The next form I am going to go over with you is our anesthesia record. So it is just a chart here that has the patient's name, the procedure, the date, the TPR, mucous membranes, capillary refill time, weight in pounds and kilograms, and the age. And then, as you can see here, we have time, temp, heart rate, rest rate, mucous membranes, the SaO2, the MAP, which is blood pressure, EtCO2, what setting our isoflurane is on, what setting our oxygen is on, the fluid rate, and then the pain score, and any kind of comments if we were to do a local block or add anesthesia or bolus some more propofol or something like that. We would have that in the comments and what time we did that. We do try to record all of these every 5 to 10 minutes. At the bottom of the anesthesia record, we have a section for the medications, which is any drugs that we use for pre-medications, induction, pain medications, and things like that. We have the name of the medication, the volume, and then our bottle ID for our controlled drug log. Over here we have emergency drugs, atropine and epinephrine. We have the risk assessment, the total time of the procedure, and then which doctor is either over the procedure or performing the procedure. Over here we have the ET tube size, who calculated the anesthesia or sedation, the start of the procedure time, the start of the actual anesthesia time. So the procedure maybe starts 5 to 10 minutes after we actually induce. So that gives us a range of time between when the patient is actually induced under gas anesthesia and IV anesthesia, and then when the doctor actually makes the first cut. And then if we do local blocks for abdominal surgeries or dentals, anything like that, we have a section for that as well. So all of this is recorded and then into the patient's record as well. So for any type of surgery that we do at our hospital, every patient will go home with discharge instructions for the owner. It will go over things that we did during the surgery, any kind of aftercare instructions, as well as medications to go home and complications that they should look out for. For a spay discharge, it would go over to keep the e-collar on at all times, to withhold large amounts of water after the surgery. Whenever the patient gets home, we would explain that she could have a small amount of water, and if she holds that down, then she could be offered more frequent small amounts of water until she goes to bed. Dinner for that night, we usually tell them to offer half of her normal feeding for that night, and then normal feeding can resume the next morning. Medications to go home for a spay procedure in our clinic is usually carprofen, which is a NSAID that you do not want to use with steroids or in patients with liver or kidney disease. So we would warn them to not use it with any other medications. If it was intense surgery, we would provide more pain medication or antibiotics and things like that, usually gabapentin in conjunction with an NSAID, antibiotics and things like that. We would advise the owner to make sure antibiotics are given on a full stomach, because it can cause upset stomachs. And then any kind of complications to look out for after the surgery if the patient licks at the incision or is too excitable and runs around and jumps on things and runs up and down the stairs. We advise against that. They need to be kept quiet for 2 weeks for the incision to heal completely. We usually have them come back to the clinic so we can recheck our surgery site, remove any sutures or staples that are external if we did not do buried sutures, and then have any kind of follow-ups like 6 months after, just to make sure everything's looking good. So here I have just a dental report card on one of our patients that we did. This goes over our information, all of our doctors that we have in the practice. The before and after pictures of the dental cleaning. This shows the grade of dental calculus, the grade of gingival disease, any pockets or extractions, if we applied doxarobe gel, and if so, it advises the owners not to give the patient any chews or chew toys for 2 weeks. This would explain if we were to send home any kind of medications. This patient did not go home with any medication, so it doesn't list any. If we were to send home medications, this is where we would put the instructions on here. If we wanted to recheck the patient's mouth, if we had to do surgical extractions or anything like that, we would have them come back in a few days just to make sure the sutures are still in place and it's healing well, no food's been stuck in the pockets or anything like that. And then the dental home care plan, what we recommend for each individual patient: dental chews, brushing, Cleansident additive, and then Hill's TD treats. And then down here we have actually typed in discharge instructions for this patient that we would go over usually on the phone. We usually give them a call immediately after surgery and let them know exactly how the surgery went, how the patient's recovering, what time we expect them to be fully awake and ready to go home. We would go over on the phone with them what medications that the patient is going home with, if any, what to expect, and when we would want to see them back. We also print out everything to go home as well, in case that they do forget anything that we go over on the phone with them. So this shows us that we did extract a very loose premolar on the right side. Since it was so loose and diseased, we don't feel that she needs pain medication to go home, but to definitely let us know if you feel that she's uncomfortable. We also trimmed her nails. She may be a bit sleepy and lethargic this evening, but she'll return to her normal self by tomorrow afternoon. You can offer her about half the amount of her normal dinner this evening and resume normal feeding tomorrow. Dr. Lively wanted her to start water additive for her teeth. I'm sending a bottle home with you. Please feel free to give us a call with any questions or concerns. And then down at the bottom, it has the dental technician that performed the cleaning, and then the doctor that did extractions and was over the procedure. And then any kind of recheck schedules down here, and then any other kind of information that is not included in this paragraph up here. So this would go home with the pet after a dental cleaning. To properly restrain a canine for a jugular blood draw, you want to have your patient either sit sternally or upright. You want to have the patient's body up against your body. You do want to have any collars or leads up out of the way. You want to hold the chin up. You want to have her body close to you, and then either have the neck face this way or face the other way, depending on how lateral the jugular is. And you want to keep complete restraint on the animal's head and body at all times. And then the technician that is drawing the blood will have access to either one of her jugular veins. For a cephalic blood draw, you can have her sternal or upright as well. So you want to have the arm rest in the palm of your hand. So you have good control of her elbow. If she pulls away, you can hold that. Her head should be resting inside your arm, so you can keep control of her head in case she pulls away. Then with your thumb, you can grab the inside bend of her elbow and then roll out. And then you can see, once you occlude the vein, you can actually see the vein following the inside of her carpus all the way up to her elbow here. And then the technician would be able to draw the blood once you have control. For a saphenous blood draw on a dog, you want to have them standing or laterally recumbent. For this large dog, we can have her stand. You want to keep control of her head at all times, so her head can stay in the bend of your elbow, so you can have control if she moves around. And then have her stand to occlude the vein. It runs from her hock to the back of her leg here. So you want to grab behind the leg and occlude it, and then you can see it pop up there right down here. You want to occlude that vein until the technician can draw the blood off, and then hold as a human band-aid for a minute. And that is how you would restrain for the 3 positions on a canine patient. For this video, I'm going to demonstrate how to properly place a dog in a cage and then remove it from the cage. So for this small patient here, I'm going to remove her leash before I put her in the kennel. Go ahead and open. Keep her head away from you in case they may be kennel aggressive. Put her in the cage, and then make sure it is properly secure and locked. And then to remove the patient from the cage, we will go ahead and get our leash ready. Make sure to not let her bolt out of the cage. So I usually slip my hand in there, put the leash around her head, and then let her walk out on her own. So to place a muzzle on an aggressive or fearful dog, it depends on how aggressive the patient is. There are many different types of muzzles that you can use. For this dog, we are going to use just the nylon muzzle, and the easiest way would be to just slip it over from behind her head. So I've got her here, and then I can slip it over from behind so she doesn't see me coming, and then tighten it up, and then there's your muzzle. And then you can remove that and pull it away. So to place an e-collar on a patient, you want to make sure you have a collar that is long enough to where it extends beyond their nose. And then once you get that length correct, you want to measure it around the girth of their neck, and then put it together. So we have hers measured correctly and it's already put together. You also want to get either a collar or some brown gauze or white gauze to make a makeshift collar where it can be tight enough on their neck to where they cannot get it off. And once you have all of that, we are going to gently slide this over her head, being careful not to hurt her eye or her ears or anything like that. You want to hold, if you have any collar with little tabs like this, you want to cover those. And then gently slide it over the head. Once you get it on, you're going to tighten it to where you can get 2 fingers under it, but to where it is tight enough to where she cannot get it off. And you can check by gently pulling that it does not come over her head. And whenever it's all the way down, it still extends beyond her nose. So this is a properly fitting e-collar. I'm going to demonstrate how to do a minimum physical examination on a dog. You want to, at minimum, do a TPR and listen to the heart and lungs. And then your doctor can do a full physical assessing joints and abdominal palpation, rectal palpation, things like that. But at minimum, before any kind of surgery or any kind of inpatient care, the technician should do a brief physical exam. We're going to start with listening to the heart. You want to listen on both sides. You want to count the beats for 15 or 30 seconds and then multiply that by either 4 or 2, depending on which one you listen for, how long. So you want to have your patient stand. Stay. Come here. Stay. So her heart rate is very low and steady. She's at about 62 beats per minute. Her lungs sound great. I listened to all the lung fields. I listened to both sides. Everything is equal, not raspy, not crackly. Her heart sounds great. She does not have any murmurs, no arrhythmias. And we could do her temperature as well. Stay. Her temperature is 100.9, which is normal. Gonna do an abdominal palpation. Everything feels normal in there. She does have a small lipoma on her ventral thorax. No other masses. Can I see your gums? Can you sit? Sit. Thank you. Her gums are nice and pink. And her capillary refill time is about 1.5 seconds. So yeah, she is great. Everything is within normal limits. Her respiratory rate was about 13. So yeah, I would grade her an ASA grade of 1 and proceed with surgery. All right, so we are going to do a TPR on this patient here before her surgery. We want to listen on both sides of her heart and listen to her lungs for any kind of wheezes or crackles, and her heart rate and rhythm. for any kind of abnormalities, and then we'll get her temperature and assign her an ASA grade. So her heart and lungs sound great. Her heart rate is a little bit elevated. She's around 220. Her lungs sound nice and clear. She has no murmurs or arrhythmias. It's okay. It's okay. It's okay. Turn it all the way. You can right there. Yeah. Just cover you. What is it? It's okay. Okay. Alright, her temperature is normal at 101.1. So her blood work was all within normal limits as well. She's young and has no heart or lung issues, so her ASA grade would be a 1. And she would be okay to move forward with surgery. Now I'm going to demonstrate how to do a cephalic blood draw on a canine. So my assistant has the patient here restraining her head against his body. We have our alcohol here. I'm going to grab her arm. He's going to go ahead and occlude the vein. I place some alcohol over the vein. We're going to get our syringe here, hold the non-dominant hand parallel to the vein with the bevel up. We're going to go ahead and insert it into the vein, draw back. Alright, you're going to let up. We have our blood sample here. Next, I'm going to demonstrate how to do a jugular blood draw on a canine. I have my alcohol here. So you want to keep your patient sitting or laying down sternally. And he has the collar up and the chin straight up. I'm going to apply some alcohol. And then with your syringe and the bevel up, you're going to hold off on either side of the thoracic inlet. Palpate for the jugular. Bring your chin down a little bit. And once you find it, okay, you can hold that off. Down underneath my hand. And then there's your sample. Next, I'm going to demonstrate how to do a saphenous blood draw on a canine. So my assistant has the patient standing. He's going to occlude the vein have my alcohol. And with my syringe, with the bevel up, I'm going to use my non-dominant hand parallel to the vein. Insert. Draw back. Okay, let up. And there's your sample there. Now I'm going to draw blood from her cephalic vein from this feline patient. I'm going to put some alcohol.
And small breach ready to go, right? Yeah, there's no stones. We're just waiting on the urine culture that Dr. makes.
And the bevel up. And there's your sample. I'm going to draw blood from the medial saphenous vein of this feline patient. She's waking up from surgery. We're going to put some alcohol.
I wrote, so the lab will need, I wrote on the catheter. And it's basically.
And with the bevel up.
And then once we get stuff out, and then propofol back, I wrote it all on the board. And then they calculate it.
There's your sample.
Once we
So I'm going to draw blood from this cat's jugular vein here. We're going to put some alcohol on her neck. Tell me if you can't see me. With the bevel up, we're going to go ahead and poke. Stop. So along with physical examinations, you do want to do some minimum databases before any kind of procedures. Each clinic is a little bit different, but minimally on every patient you want to do a packed cell volume and total solids, a blood glucose, a BUN, which is a kidney value, and then an ALT, which is a liver value. So that gives you a little peek inside some of the basic functions of your patient. If any of these were abnormal, then you would run extra lab work, x-rays or EKGs, ultrasounds, and things like that. Just depending on what was elevated, you may postpone the procedure to do more tests like bile acids or an echo or things like that. So your minimum database is very important. So for a anesthetic and pre-anesthetic protocol, you will always get with your doctor. If my patient here, which is a 6-year-old female spayed pit bull terrier, if she was going to get a grade 2 dental, our protocol would be pre-medicate with gabapentin at 10 milligrams per kilograms and trazodone at 8 milligrams per kilograms, both of those PO. And then we would also pre-medicate with acepromazine at 0.05 milligrams per kilograms and butorphanol at 0.03 milligrams per kilograms, and give those IM. To induce this particular patient, we would use Valium at 0.2 milligrams per kilogram and then propofol at 6.5 milligrams per kilogram to effect. During the procedure, we always do IV fluids. The rate of fluids can change between patients depending on heart conditions and things like that. But she is completely normal. Her ASA grade is a 1, so she would be at 50 milliliters per kilograms per day. After the procedure, at all of their TPRs, we would assess her pain score if she were to have any kind of extractions during her procedure. Those would be locally blocked with bupivacaine. If she was found to be painful at any of her TPRs after her procedure, then you can do another torb injection. They would go home on gabapentin and antibiotics if we were to pull any teeth or anything like that. Okay, so I'm going to make an entry in our drug log here. We got a new bottle of gabapentin, so I'm going to go ahead and put that in our log. So we're going to have today's date.
She's recording something. Hold on, Shannon.
And it doesn't have an NDC number.
Oh.
Our lot number going to be 0214219.
That's like cheesy puss right there.
Do you want to get lively?
I think it's gonna have to come off.
And this is a bottle of 500. And then I'm just going to put my initials here. So this shows you gabapentin, 500 tablets, 50 milligrams. And then I have our new inventory logged here. So this is one of our anesthesia machines. All of the parts on here I'm going to describe to you. This is our vaporizer. We use isoflurane. Then we have our pressure gauge here that would go up with any kind of increase in pressure from the lungs or anything like that. Then we have our reservoir bags down here. We have our pop-off valve that can also be screwed in, but we have just our finger pop-off valve. We have our O2 over here. Our scavenging system is our F-air. Our O2 comes from tanks that are in a separate area. Then we have our CO2 absorbing pellets. We have our Cardell here that does our ECGs, all of our monitoring and things like that. Our SpO2 clip is down here, our ECG clips, and then our CO2. We also have our blood pressure cuffs that also connect there. On the anesthesia machine, we also have our inhale and exhale ports. You would have your tubes connected there, and that is what is in our anesthesia machines. So the two different types of tubing here is our non-rebreathing system. We use this for smaller patients, usually anything under 15 pounds. We'll use a non-rebreathing system. This just makes it easier for the patient, less workload on them. It bypasses the system here, and each breath that they take has clean gas and clean air. They're never rebreathing the same gas that they have exhaled. The next system is a rebreather. So once this is hooked up, the patient does most of the breathing work for them. A portion of what they breathe out, they also breathe in the next breath. So we save this for our larger patients that are usually over 15 pounds. We have a couple options for inductions for masks. We usually don't mask down animals. We reserve these for like flow by oxygen for animals that come in just needing some extra support. Large ones, medium ones, and then very small ones. Some practices use induction chambers for feral cats or an animal that they can't handle or something like that. We don't have those here. We are fear-free practice and try to not have to do that. That causes an overload of anesthesia. You have to fill the whole entire box up with isoflurane or the anesthesia gas that you're using. It's uncontrolled how much the patient is getting. You have to let them get sleepy enough inside the box, and then you have to open the box to get the animal out, and it's exposing everybody else to the anesthesia. So we don't really use those here. If you were to use one, it would be a box that is connected to your tubing to your anesthesia machine, and you would literally just pump O2 and isoflurane into the chamber until the patient gets sleepy enough that you can handle. So I'm going to perform a leak test on one of our anesthesia machines here. The first thing you want to do is close your pop-off valve. We have that closed. We're going to go ahead and occlude the top of the tubing either with a finger or your palm. Make sure there's a good seal there. Use the flush valve to fill your reservoir bag. I'll show that. And then you want to fill it to about 20 centimeters of water, and you want to hold that for about 5 seconds and make sure it doesn't leak. So that is a confirmed leak test. Our anesthesia machine is A-OK. There are no leaks. So this is Ashley Harvey. She's my preceptor, and she will be assisting me or videoing me in the rest of this video. Okay, so we're going to put an IV catheter in Miss Maybell before her surgery. We are going to go ahead and hold off so we can palpate the vein. With a 40 blade, you want to clip a nice area right over the cephalic vein. And then you want to do a bullseye scrub with chlorhexidine and then alcohol.
Miss Erica,
What you need?
are you available to help me roll with my next demo? Or are you?
Yeah, I have an appointment on the way, so maybe not.
No, that's okay. I will wait. Thank you, though.
All right.
I have an appointment that's supposed to be here right now. I should probably get it.
With your catheter with the bevel up. And to insert till you have a flash. Okay. We have our cap on. There's a bunch of different ways to tape. Everybody's going to do it a little differently. And put tabs on your tape so it's easy to take off. It's okay, man. You're doing very good. Yes, you are. One last tape here.
You ever gotten stuck to the wig?
Alright, and then with heparinized saline, we're going to go ahead and flush
Correct.
just to make sure this is patent.
Yes.
Okay.
Feels good. And then we'll put some no chew on here, and she'll be ready for her IV fluids. So I'm going to place a saphenous catheter in this patient here. We have her in lateral recumbency. I have all of my things. I have some catheters to choose from, my clippers, my cap, some scrub and alcohol, and we will go ahead and place this. I'm just going to clip some area around her vein here on her saphenous vein. And this patient has very short hair, so there's not going to be too much hair that we can clip, but we'll try to get as much as we can. Now we're going to do a bullseye scrub with Chlorhex. And then alcohol. We're going to do that 3 times. You're doing so good. You got that?
Mm-hmm.
I'm going to prep the catheter with the bevel up. We're going to insert. Okay, we're in. And we have a flash, so I'm going to.
It's okay. It's okay. Stay.
tape job is going to be different from technician to technician. You always want to have tabs on your tape, and you don't want to make the tape too tight to where it's cutting off circulation, but you want it tight enough to where it doesn't slide. You do go, babe. Our heparinized saline here. We're going to flush it to make sure it is in. And we have a good flow there. Then we're just going to wrap it with some no chew so she'll be ready for her surgery. And that's it. Whenever you place a catheter in a patient, to confirm that you are in the vein and not outside of the vein, you will initially get a flash of blood back into the hub of your catheter. At that point, you can flush it with saline and feel above the catheter and see if you can feel the saline going through the vein. You can watch around the area of the catheter and see if you observe any kind of blowing or, in other words, the flush going under the skin and not through the vein. That would indicate that you are not in the vein anymore, and you would need to readjust and recatheterize. So I'm going to do a sub-Q injection on this cat here. We're going to go ahead and prep the area with an alcohol swab. We have her injection drawn up. We're going to tint her skin, insert the needle, draw back, and inject. And that's it. Alright, we're going to give an IM injection for this pup's pre-meds. Hold my thumb between her muscles here and go in, pull back, inject. I'm going to go ahead and give this cat her induction drugs IV. I'm going to put some alcohol. With the bevel up, we're going to insert into the vein.
Forgot to mention she had dome tour.
Oh, great. Okay, once you have a flashback, Courtney's going to let up, and then we're going to inject. That's it. We're going to go ahead and induce this patient for his neuter. I'm going to flush his catheter.
This is Dr.
Feels
Graham.
very good.
Oh. Joe Graham is Dr.
And he's going to get Valium.
Let me look at
I'm
my
sorry.
No, that's fine. I'm just trying to think.
Flush that through. And then propofol to effect. this slowly. Going to measure. Okay. That looks fabulous. Now to inflate the cuff properly, we're going to hook him up. Megan is going to breathe for him, and I'm going to listen for air to flow around the tube, and I'll inflate it until I cannot hear it any longer. Ready? Yes. One more time. Sounds good.
Good.
Okay.
Alright. And we're gonna hook him to his back.
I'm gonna apply some eye lube while they're hooking him up. So once you've intubated your patient, you do need to confirm that you are in the trachea, not the esophagus, or too far deep into the trachea. That's why you want to measure your tubes before you actually tie them in. If you are too far into the trachea, you will go into either the left or right bronchi and only be supplying oxygen and gas to one side of the lungs. Your patient will be light during anesthesia, and the oxygen saturation will be low. There will be indicators that your tube is too far in and is only inflating one part of the lungs instead of both equally. So you do want to make sure you measure your tube and make sure that your SpO2 is reading close to 100 ideally, and that your patient is adequately sedated throughout the procedure. To express the bladder of your surgery patient, if they have a full bladder for an abdominal surgery, you want to come from behind, make sure the tail's out of the way, palpate for the bladder. Once you feel that, you can gently express, and they should express their urine. You want to make sure that the bladder is empty before you open the abdomen, so you can easily locate all of the internal organs that you need and not have to go around the bladder. So now that he is flipped on his back, he's got everything hooked up, we're going to go ahead and start clipping. He's getting neutered today, so Still recording. I'm gonna make sure he's clipped close to where we're doing the actual incision, so there's not stray hairs right over the incision. And we're gonna use the vacuum. Now we're going to start scrubbing. We're going to use chlorhexidine scrub and alcohol. We're going to do a bullseye scrub. If anything touches hair, that scrub is done. We're going to just lay a piece of alcohol gauze over the incision so it doesn't get contaminated during our movement to surgery.
So I can take the trough if you want to take the patient. So completely disconnect? Yes.
You wanted to have the towel?
No towel.
If he were a larger dog, we would have used the towel and multiple people to bring him in, but because he was small, I can support his neck and his body.
You want to move him down, Kristen.
All the way down here.
The whole thing down. Yeah. Yep, perfect. And 110.
Alright, so we have our patient anesthetized here. We're going to go ahead and hook him up to all of his monitoring. We have his pulse ox here. That's going to do his SpO2 and heart rate. Then we're going to do his ECG. And then blood pressure. We've already measured him and he is at a cuff size 3. And then we're gonna do the esophageal thermometer probe. Probably just get a cup. That's great. And that's it. And all of his monitoring should be picking up there after it stabilizes. I'm going to monitor this patient. We have temp, heart rate, respirate, mucous membranes, SpO2, and his blood pressure and EtCO2. We have the levels of his isoflurane and O2, and then fluids, and then his pain score. We try to do this about every 5 to 10 minutes.
I'm using my watch. It's 12:17.
12:17. It has been 5 minutes. And we have everything here that we read off of. His temperature is reading at 99.6. Heart rate is at 107. Respiratory rate is 26. He is nice and pink. His SpO2 is 100. Blood pressure is 130. EtCO2 is 57. His ISO is at 1.5. Oxygen is at 1. Fluids are still at 110. There we are. To place an orogastric tube, first you will select the correct tube size and then measure from the tip of the nose to the patient's last rib, and then mark your tube at that area so you don't extend beyond the stomach or have the tube bunch up in the stomach or not go far enough. With the patient in lateral recumbency, hopefully intubated with the ET tube cuffed, you will lube the end of the orogastric tube and slowly advance it down the esophagus. If your ET tube is correctly inflated, you won't have any trouble not going down the trachea. And then you just slowly and easily pass the tube down to the stomach. Your contents should begin to flow out the tube, and then you do want to make sure you kink the tube so nothing will go back into the stomach, and then as it's kinked, then you'll remove the tube. To select the size of endotracheal tube that you want to use for your patient, there are a couple different ways that you can teach yourself how to select the correct size. You do want to have a few different sizes available at the time of intubation. Usually one size and then a size above and a size below. There's a small chart that you can use that gives you an estimate of how large the animal is in kilograms, and then it gives you a range of tubes that may be appropriate, but the confirmation of the breed will definitely have a difference in the tube size that you select. Brachycephalic dogs do look like they can take a large tube, but in fact they will have a much smaller diameter, so you will have to select a small size, and that comes with just time and knowledge. You want to select the largest tube possible without causing trauma. to the trachea. It just takes time to know what feels right and what's too loose and what's too tight. So you can go by the chart that's in the book. It has kilograms for dogs and kilograms for cats. So to properly leak test your endotracheal tubes, you're gonna get your syringe, inflate it until your cuff is completely inflated. You want to submerge it in water, and if you see any bubbles anywhere, as well as where your tube meets, and if it stays inflated and there's no bubbles in the water, then you have a tube that is not leaking and is okay to use for surgery. If unfortunately your patient codes or goes into cardiac arrest under anesthesia, hopefully you would have an ET tube in place already. You could either use an ambu bag to manually give breaths after it's attached to the ET tube. Preferably you would have multiple people in the room helping when doing chest compressions. The method and pressure of compressions depends on the size of your patient. So if we had a small cat, then you can use just small force over the heart. If you had a larger patient, then you would want to have leverage and manually do compressions. And then you would want to have someone giving breaths, whether it was with your ambu bag or with your tubes attached. You can give a breath with your reservoir bag after you close your pop-off valve. You can manually give breaths that way as well. I'm going to demonstrate how to scrub in for a surgery. I've removed all of my jewelry, my rings, my watch, name tags, pins, everything. So I'm going to go ahead and wash my hands. Now you want to put on your cap and mask. I've got my hair up. Now we can begin the process of actually scrubbing. So this comes with a little nail pick. I'm going to go ahead and clean underneath my nails. Then you want to wet your scrub. You're going to always keep your hands above your elbows while you're scrubbing. We're going to start with our fingertips, and then we're going to do at least 10 passes on each surface of everything. Now we're going to do our fingers, all 4 sides. going to move to our palm. And then our thumb. And the outside of the hand. Now we can move to our forearm. Now we're going to move to our other hand. Do the same thing. Once we're done, now we can rinse. We're going to rinse from our fingertips to our elbows.
Find your towel. Yep. Yes. I think we did last time. I think we made it like 100. Like, are we? Yeah, one at first, girl. Yeah. Okay, good. This is weird.
Okay, if you want to get close and show this, with my fingers still in the cuffs, they never leave the cuffs, I'm going to close the glove.
Yes. She's good. When you open that, I'll drop this top back to you. Just grab that. This is strange. We have 15 gauze. As we should. Perfect. And 12 instruments. So we'll recount at the end of surgery to make sure nothing's left us. Before I clamp these, do you want to see if that's an okay feel?
That looks good. You're open. It's right here. Okay. Place. Excellent. Thank you. All right. Starting. Okay. Thank you so much. Yes, that would be great. Perfect. Could do a little on this side. Excellent. Wonderful. And then I'm going to strip them.
curved okay?
Curved is perfect. Thank you. And one more set. Beautiful. Don't mind blotting a little bit right there. Actually, the forceps would be great.
So I'm going to show moistening of the tissues. We have some sterile LRS. Do you want it blotted or dripped?
I'll blot it.
So there are many roles of the surgery technician that is scrubbed in. One of the main roles would be to pass sterile instruments to your surgeon. Another one would be to handle the tissues properly and keep them moist. Also to make sure everyone stays sterile. If there was a break in sterilization, whether your glove was punctured or an instrument was dropped, if the instrument is needed to finish the procedure, you may do a flash sterilization, which takes a few minutes to sterilize the individual instrument again. Or if your glove is ripped or punctured, you can have someone else bring you a new pair of gloves and place those over top of the ripped gloves. You also want to make sure you are maintaining bleeding. If you see any kind of vessels that are leaking or a lot of blood on the outside of the incision, then it would be the sterile technician's job to blot away the blood and pass hemostats.
We have our feline spay here. She just got done with her surgery. So now we're going to go ahead and clean up her surgery instruments. But we just spayed this feline patient.
My name is Ashley Harvey, and I'm a licensed veterinary medical technician and preceptor for Kristen Ward. Unfortunately, during the time frame of this assignment, we did not have a feline neuter scheduled, but I have seen Kristen successfully assist in a feline neuter procedure before.
Once the surgery is complete, we're going to go ahead and go through all of the instruments to make sure everything is still here. We had 15 gauze in before the surgery and 12 instruments.
I did have to muzzle her.
Okay, I remember that because
She got a little nippy.
There's 15 gauze. We're going to carefully look for our sharps. There's a needle here. One, 2, 3, 4, 5, 6, 7, 8, 10, 11, and 12 instruments. And then I will put my sharps in the sharps container and we'll clean up surgery. So at the end of the day, we're going to break down the surgery room and go ahead and deep clean it. After each surgery, it is cleaned before the next patient. But at the end of the day, we're going to sweep and mop the floor, wipe down the lights and every surface, as well as the doors, and vacuum and sweep underneath all the machines. Take all the trash out. If there were any instruments left or sharps from the last surgery, we would put the sharps in the sharps container and put the instruments in the soak. But that has already been cleaned up, and so we do not have any instruments or sharps to put away. We're going to go ahead and next we're going to sweep and mop. And you want to use a designated broom and mop for surgery. So both of ours are color-coded red. So that broom was red and this mop is also red, so that everybody knows that this is only used for surgery. After that is complete, your OR is ready for the next day. I'm going to demonstrate how to pre-soak and pre-clean our surgery instruments. We're going to use distilled water. We have a distilled water jug here. We're going to go ahead and put that over our instruments. And then we have our surgical instrument cleaners. We're going to use a pump of that. And then we're going to let that soak. And then we'll come back and rinse it. So after these are done pre-soaking, we're going to go ahead and rinse them with cold distilled water. So now we're going to do our scrub with some warm water and detergent. With our soft bristled brush, we're going to go ahead and clean these instruments, especially in the crevices and the handles. Alright, now those are scrubbed. Now we're going to rinse them off with distilled water. And then place on a lint-free cloth. So now all of the instruments are opened and on the cloth. We're going to go ahead and put the other end of the cloth over it so they can dry. And then once they are dry, we're going to come back and use the ultrasonic cleaner. So after we have cleaned our instruments, we're going to use the ultrasonic cleaner. We have a gallon of water in here, and our instruments, we're going to use 1 pump of our instrument cleaner. It says it can be used for ultrasonic cleaning and manual cleaning. On the back you have the directions. It says use 1 pump per gallon of water. So we have a gallon of water in here. We're going to use 1 pump. Now we are going to put the lid on. This runs for 10 minutes.
How you doing? 200.7.
And now it's going. Then we'll come back and rinse these off, and they'll be ready for a pack. I'm going to demonstrate how to wrap a pack. So we have our 2 wraps here that are already out. I have my instruments that I'm going to lay on top of a blue towel. Put my instruments on the towel. Our gauze that have already been counted out. We use 15. I'm going to put our towel clamps on top.
The first night. All night. I was like, now wait a minute.
Then we're going to add our indicator strip. And then we have our drape.
It's like, I know what that means.
I know. I said, I hope I don't see y'all again for a while.
Xander's a boy.
So we're going to fold the first layer over, leaving a tail, then a side, leaving a tail, the next side, and tuck it in. Then for the outside, we're going to do the same thing in the opposite direction. Here's our pack that is wrapped. With the indicator tape, I'm going to label the pack. With my initials and the date. Then we'll go ahead and autoclave this. Now I'm going to demonstrate how to fold a gown for a gown pack. We have the inside of the drape face down on a table. You're going to take the arms, fold them towards the middle. Fold over. After folding the edges in, we're going to fold it in half lengthwise, making sure the neckties are out. And we're going to fold it in an accordion style. Then the neckties are going to be on the top. And we are going to fold our towel in the accordion style and then into quarters. Place that on top. We're going to put our indicator strip in the middle. And we are going to go ahead and wrap our gown pack. At this point, you can put your tape on and label it with the size of the gown, your initials, and the date. Now this gown is ready for autoclaving. So this is our autoclave. This is how we sterilize all of our instruments. It works by using distilled water that is heated electrically until the water is turned into steam, and the steam builds up pressure. That steam then sterilizes the instruments, and then once the process is done, the steam then turns back into condensation and then turns back into the water. To run an autoclave, you want to go ahead and get your packs that you have prepped. You want to put them inside on the grate of the autoclave. You do not want it to be stacked too full. You don't want anything to touch the internal parts of the autoclave. You want to make sure your water is high enough, and then we can close the autoclave here, set it to run. These are packs, so we would literally just press pack and start, and that has its own settings for temperature and time. Usually time takes about 45 minutes for them to be sterilized and then the steam to evaporate. The temperature will probably get between 250 and 270 degrees Fahrenheit, and then your pressure is needs to be between 15 and 27 psi. So to maintain the autoclave on a weekly basis, you want to get a damp cloth with soap and wipe down the outside. You also want to check the gaskets on the door for any kind of damage. Wipe down the door. Wipe down the tray. And then you also want to, on a weekly basis, drain the machine. So you would pull this tube out, drain it into a bucket, and then refill the reservoir with distilled water. On a monthly basis, you do the same thing, and as well as clean the filters on the inside of the autoclave, and then run speed clean through on an actual cycle, and then rinse it and follow that with a rinse cycle of distilled water, and let that cool. So after your packs have been autoclaved, there's a couple ways to tell that they are sterilized. I'll show you on this pack that just came out of the autoclave. We have our indicator tape that starts out with white strips. When it is up to temperature and sterilized, they turn black. Also, whenever you open it, there will be a indicator strip inside as well, that starts out looking like this, and once it is sterilizing up to temp, it turns black. I'm not going to open that, but you can see through this pack with the tape they have turned black stripes, and your indicator strip that is inside the pack is black as well. That's how you know that your pack has been sterilized. So we're going to do a suture removal on this patient here. She had a laceration on her chest here. You can barely see the sutures, they're light pink. Her incision looks great. There's no raised areas or scabs or anything. The scar is already turning white, so it's healed very well. We're going to go ahead and remove these.
There's only 2.
Yep, so there are her 2 little sutures. I'll show you her incision. You see it right there? It's all closed. Like I said, there's no scabs or the incision's not open or anything like that. There's no oozing. Her incision is healed well and her sutures are out.